Good morning, everyone. So this week we are continuing our lectures on dermatopathology, and we have covered multiple lectures now discussing all the different aspects of dermatopathology. And let me just take care of the camera. Yeah. So we have covered a lot of different aspects and different tissue reaction patterns in the previous videos. And this week we'll be continuing our discussion on vesiculobullous reaction pattern. Now, last week we were studying spongiotic tissue reaction pattern, and we know from that spongiosis is somewhat of a finding that can be seen in a lot of different disorders. One of them being vesiculobullous reaction pattern. Formation of all vesicles will start from some bit of spongiosis, okay? And when the spongiosis crosses a threshold, it will become larger and become a vesicle. And if the vesicle becomes larger, it becomes a bulla. That's why it's vesicobullous reaction pattern, okay? Yeah. So whenever a vesicle is trying to form, it will go through stages of spongiosis, vesicle, and bulla. Now, in order to understand what exactly is vesicobullous reaction pattern, we need to know where the split is occurring. We all know that epidermis and dermis are the two major layers of skin. Okay, so if this is a small diagram and this is the dermoepidermal junction and this is the epidermis, where the split is occurring will decide what the disorder is. It can also occur at the level of dermoepidermal junction. Clear? Where the split is occurring will decide how the vesicle will look. Okay? So if it occurs a bit at the top, nearer to the top, the roof would be very, thin, while the floor would be thicker. If the roof is thin, the vesicles would have a flaccid look to it or a weak look to it, or it will look like this, a shagged, like a kind of loose skin covering it. Okay? If the split is very much at the top, you might never see this roof, okay? You will only see erosions, like you say in Pemphigus Foliaceus, isn't it? If we go a bit deeper at the level of stratum basale, the roof will be substantially there, but still flaccid. It won't burst like in Pemphigus Foliaceus, but it will be there a bit flaccid, a bit loose, and that is what you see in Pemphigus Vulgaris. If the split is deeper, like at the dermoepidermal junction or just below the dermis, since now the roof is thicker, you will have a tense roof, okay, a tight roof, which is roughly at perpendicular to the skin, roughly at 90 degrees, and it will be tense, tight, because there will be a lot of pressure coming from inside to outside, okay? And that is what you see in bullous pemphigoid. So using the different slides in this lecture, we will understand what is the vesicobullous reaction pattern which underlies all of these vesicobullous disorders that we have just talked about. So without much further ado, this will be a long lecture, so I'll go faster in all the slides. Let's start a discussion on vesicobullous reaction pattern. Now, vesicles or bulla at any layer of the epidermis or dermoepidermal junction. You need to have a vesicle or a split into within the layers of the epidermis or at the dermoepidermal junction. The split can happen because of these defects, and the defects is there in the adhesion of keratinocytes, which can be congenital or acquired. Understand that there are two cells or two keratinocytes. They will be attached to each other by using desmosomes, hemidesmosomes tight junctions. They are attached to the basal layer or to each other with these kind of attachment molecules. Okay. If there is any defect in the attachment molecules, the cells will get separated from each other. Okay. And when they get separated from each other, they will lead to formation of spongiosis or the look of spongiosis. And when this spongiosis is larger enough, it will form vesicles, large enough to cause a split. So you have a split to form a vesicle. And if it's larger, it becomes bulla. Okay. In order for the split to form, the attachment should be lost among the keratinocytes. And this attachment can be lost either due to a defect in the mutation or a defect in genes, that is genetic mutation at birth, which we see in epidermolysis bullosa group of disorders, or it could be because of a pathology, which we see in pemphigus group of disorders, or it could be because of infection that we see in bullous impetigo, okay, or even in staphylococcus skin scalded syndrome. That could be the reason for the split. The defect has to be there in the adhesion, okay. So again, this is a diagram that we had discussed last week in the spongiosis video. We have individual keratinocytes, okay? So these are the keratinocytes, and while the dark blue one are the desmosomes, which are included to attach two cells together. And if those cells, the attachments are lost, it will lead to spongiosis. Okay? And if the defect is larger, it will lead to a vesicle. And if this vesicle becomes too large so that the junction molecules are also lost, it will lead to a large split. Large split. Okay? And that is what is known as vesicobullous reaction pattern. Vesicobullous reaction pattern is a reaction pattern shown under a microscope in which there is a split between the layers of the epidermis, between the epidermis or dermis, or it could be because at the level of sub-epidermis, just below the epidermis. Let's move forward. So we will not go in detail about the role of adhesion molecules. There are four major families of adhesion molecules, which are the cadherins, integrins, selectins, and the immunoglobulin superfamily. There are two specialized intercellular junctions, which are the desmosomes, along with along with hemidesmosomes and the adherens junctions. You need not remember that. There are also tight junctions, but their major function is transmission of signals. Transmission of signals. They are not so much important for structures. For structure, the important molecule is desmosomes. Okay, so that is where the adhesion, the attachment of individual keratinocytes come. Let's move forward. So with that background, that what exactly we mean by vesicobullous reaction pattern, we mean that there is a split among the layers of the epidermis. We'll move forward and discuss each and individual disorders. But before we discuss the disorders, we need to know how to classify vesicobullous reaction pattern. And with the classification, it will make more sense about the disorders that we'll discuss. Let's move forward. The classification can happen, number one, on the basis of anatomical level of split. That is where exactly is the split happening. It can also be because of mechanism responsible for the split. Either the cells are dying or the desmosomes are getting destroyed or whatever the reason may be. This could be another method of classification. The third is inflammatory cell component. That means in the blister, what all cells you are seeing? Are you seeing neutrophils predominantly? Or are you seeing lymphocytes predominantly? Or are you seeing eosinophils predominantly? Or very rarely mast cells, histiocytes, or other cells? So what is the inflammatory cell component? On the basis of these three parameters, you can divide vesicobullous disorders: anatomical level of split, mechanism responsible for split, and the inflammatory cell component. So let's move forward and see how we classify the disorders. We have the anatomical level of the split, we have the mechanism responsible for the split, and we have the inflammatory cells inside the bulla or the vesicle. On the basis of anatomical level, we can divide from top to bottom: subcorneal, that is just below the corneal layer, the stratum corneum; intra-epidermal, that means in between the other layers of the epidermis, which includes the stratum granulosum and stratum spinosum; Supra-basal, that means only the basal layer is there in the basal layer is there in the floor, while all the other layers of the epidermis are at the top; and sub-epidermal, that is below the epidermis, essentially separating the epidermis from the dermis. Okay, let's move forward. In the mechanisms, we have four major mechanisms. Spongiosis, that is how nearly all vesicles start. Okay, we start from the milder spongiosis, which coalesce together, come together to form large vesicles. Acantholysis, that means cells which are getting separated from each other and forming acantholysis. This happens when desmosomes are attacked, when desmosomes are destroyed, which we see in Pemphigus group of disorders. Okay. Ballooning degeneration of keratinocytes. This is most commonly seen in infectious disorders like herpetic infections, okay, in which the keratinocytes itself are getting destroyed. And junctional separation, in which there are genetic mutations because of which the junction is not properly made, and that we see in epidermolysis bullosa group of disorders. Okay. Regarding inflammatory cells, we can have neutrophils like we see in dermatitis herpetiformis or linear IgA disease. We can have lymphocytes, which is predominantly seen in your pemphigus group of disorders, and eosinophils that we see in either arthropod bite reactions, bullous form, or bullous pemphigoid, or drug-induced vesicles. Okay, so in these disorders, you will see more of eosinophils. Now remember, when we say more of eosinophils, we don't necessarily mean that eosinophils more than lymphocytes. We mean that eosinophils more than the usual number that we usually find. Okay, remember, all of these inflammatory cells are part of cells inside the blood. Whenever there are inflammatory cells inside the vesicle, they will be composed of neutrophils, lymphocytes, eosinophils, histiocytes. Okay, but depends on the individual proportion. You say that it is more of lymphocytes, more of eosinophils, more of neutrophils. So what is the predominant cell type inside the infiltrate will help you decide that what disorder you're looking at under a microscope. Okay, let's go forward. So this is a recap from our lecture on histology of the epidermis. Just to recapitulate what exactly are the layers of the epidermis. From hair to hair is stratum corneum. Okay. This blue layer, this basophilic layer is stratum granulosum. Okay. From here till roughly here is stratum spinosum. While single cell layer thick, one cell thick layer, this layer is stratum basal. And below that, here, this is the basement membrane zone. This is the dermo-epidermal junction. Okay, so we are clear about the order of layers so that we can better understand where exactly the split is happening. Okay, if you really want to know in detail about the histology of epidermis, we already have a lecture present in the channel playlist. So go back to search for that playlist and learn more about the normal histology of the epidermis. Let's move forward. So with that, let's start our discussion on individual disorders. I have used the level of split as the classification mechanism initially and majorly. So we'll go one by one from top to bottom, discussing different levels of splits. Okay. So first we have the subcorneal or intracorneal split, in which the split is just below the stratum corneum. Okay, let's move forward. The split is within or just under the stratum corneum, and it can be seen in varied disorders, a lot of different disorders. So let's start discussing major disorders one by one. Starting with impetigo. In impetigo, since we know that it's because of an infection, and we all know that the immune cells that will come first at the site of infection are neutrophils. Okay, so there is subcorneal collections of neutrophils, and whenever there we will encounter a collection of neutrophils, they will form or they are known as microabscess. Okay, so any collection of neutrophils is an abscess, and when we speak about histology, we use the term microabscess because we're looking at microscopically, isn't it? Few acantholytic cells can be seen because these neutrophils will secrete enzymes, and because of the action of those enzymes, the keratinocyte will get separate. And when any keratinocyte, see, this keratinocyte is bound by another keratinocyte. But if this cell would have been an individual cell, it will form a bit of a spherical shape. And this is nothing but an acantholytic cell. So a acantholytic cell is nothing but a keratinocyte with no attachment to other cells, assuming a bit spherical shape along with a large nucleus. Majority of the volume of the cell is occupied by the nucleus. Inside the vesicle, you will see gram-positive cocci, which is majorly Staph aureus. So it is present there. Now, a bit different is staphylococcal skin scalded syndrome. Okay, in that syndrome, it's majorly because of the toxins mediated by the organism. The organism secretes toxins, and that toxins leads to destruction of the epidermis. I will not be going to detail what exactly is the pathology of S4, but remember that if a toxin is causing the issue, not the organism, you will not see any organism in the vesicle, and the inflammatory infiltrate will also be a bit less. So if you see more inflammatory infiltrate, you will see gram-positive cocci in the vesicles. You will see a lot of neutrophils. Consider impetigo. Okay. So look at this slide. Look at this slide. Let me change. The color, yeah. Can you see that this corneal layer is a lot destroyed? Okay, it's not proper. Below the second line, you can see the spinous layer is there. You can see the basal layer is there. A little bit of granular layer can be seen here. But look at the collection of neutrophils. It's predominantly involving the stratum corneum. It's above the stratum corneum, and it's filled with neutrophils. Okay, this is a neutrophil. Okay, so it's filled with neutrophils. Neutrophils forming microabscess. Microabscesses. And these are all filled with neutrophils. So we are seeing neutrophils in the corneal layer. Such large number of neutrophils inside the corneal layer should make you think of impetigo. Now look at this. There's a milder perivascular lymphocytic infiltrate, but there are few neutrophils inside also. Let's move forward. Now this is a biopsy from S4, and you can see compared to the previous slide, the inflammation is less. And you can also see that the neutrophils are less, and the organisms were not shown in the previous slide, but trust me, no organisms would be seen because it's a toxin-mediated vesicle. A toxin-mediated vesicle. We are clear about it? So in SSSS, you will see no organisms and a cleaner or a relatively cleaner vesicle with less inflammatory infiltrate, less neutrophils. We are clear about it? Let's move forward. The second disorder is Pemphigus Foliaceus. So I will just discuss the histopathology, not much in detail, because uh, disorders like Pemphigus Foliaceus, Vulgaris, Bullous Pemphigoid, they require a separate discussion of their histology because it's such an interesting pathomechanism of Pemphigus group of disorders that maybe in the future when I'll make a video on the pathomechanism of Pemphigus group of disorders, it's a very interesting mechanism that you encounter. So we'll just discuss the histology here. In Pemphigus foliaceus, you have a superficial bulla with a split high in the granular layer or directly beneath the stratum corneum. Okay, so now you understand either the split can be just below the stratum corneum or high up in the granular layer. So it's roundabout in the top 1/4 or top 1/5 of the epidermis. That's why we include Pemphigus foliaceus in a subcorneal blistering disorder. The bulla can have fibrin, some neutrophils, and scattered acantholytic keratinocytes. Eosinophilic spongiosis can be seen, and if you have looked at our lecture last week on spongiotic tissue reaction pattern, Pemphigus foliaceus was mentioned in one of the examples of eosinophilic spongiosis. The superficial dermis is edematous, it is swollen, okay, it is swollen, and mixed inflammatory cell infiltrate with eosinophils and neutrophils are also seen. That we are talking about the dermis, not the split, okay? If you do direct immunofluorescence, you will see that C3 and IgG are majorly the components that we see. Okay, in direct immunofluorescence, in intracellular staining. Okay, let's move forward. Now look at this slide of a subcorneal split in Pemphigus foliaceus. Okay, and this I've taken from Pathology Outlines, a great resource. These are all individual line acantholytic cells. And if you can see that majority of the layers of the epidermis are still intact at the floor. So you can have granular layer, spinous layer, basal layer, okay? But the split is just above the granular layer. Can you see that this whole layer is made by dark blue staining cells? The reason for that is that this whole area is granular layer and just above that you have the split. Okay. And the split consists of multiple acantholytic cells. In fact, you can also see a mild upper dermal infiltrate composed of mixed cells, lymphocytes, neutrophils, eosinophils, all. You can see a bit of trapped acantholytic cells here also, some acantholytic cells here also. So what essentially you will see in a biopsy of Pemphigus foliaceus is a subcorneal or a supragranular layer split with acantholytic cells with mild upper dermal edema with perivascular infiltrate composed of lymphocytes, eosinophils, and neutrophils. Clear? Let's move forward. The third is SCPD. SCPD or subcorneal pustular dermatosis. In this dermatosis, you have a subcorneal pustule in which you have predominant cells of neutrophils more than eosinophils. Okay, so eosinophils can be there, but neutrophils are much, much, much more than eosinophils. Why? Because wherever you see a pustule, there are neutrophils. So that is a way to remember subcorneal pustular dermatosis. That means a disease in which there is subcorneal collection of neutrophils. There are few cantholitic cells, and the upper dermis has mixed superficial perivascular inflammatory cell infiltrate. Clear about it? Let's move forward. So look at this slide, and I've taken this from Whedon's 5th edition. This is the stratum corneum. This is the granular layer, and you can see that the granular layer is separating now. Okay, and the stratum corneum is at the roof. Okay, and in between them, you can see a huge collection of neutrophils. These are all neutrophils. So a huge, in the microscopic sense, a huge collection of neutrophils should be, and it is, do you realize that as compared to Impetigo or Pemphigus Foliaceus, this is looking more localized, more grafts together, more solitary. Okay, somewhat that is mostly a localized collection of neutrophils. So that is what you are actually looking at is a pustule. So subcorneal pustular dermatosis. Now you get the drift. Let's move forward. There are other examples that also show subcorneal split, like IgA pemphigus can show, Miliaria crystallina, we have discussed that in the spongiosis video, acute generalized xanthematous pustulosis, remember pustulosis means newts, erythema toxicum neonatorum, and transient neonatal pustular melanosis. So these are other examples that we see in subcorneal splits. Okay, let's move forward. So we have discussed a bit about subcorneal split. Let's move a bit lower down and see intra-epidermal split. In intra-epidermal split, you will have stratum corneum and stratum, let's say basal. Anywhere in between, if a split occurs, it's an intra-epidermal split. Okay. If a split occurs just above the basal layer, it is supra-basal. But apart from, and if it comes below stratum corneum, that it is subcorneal split. Apart from that, any split that happens in between is intra-epidermal split. Okay, let's move forward. The split is between the malphigian layers, which is another word that we use for spinous and granulosome layer. The major mechanisms involved is spongiosis, ballooning degeneration, but remember all the mechanisms: spongiosis, ballooning degeneration, junctional collapse, okay, cellular acantholysis. All of the mechanisms can have an intraepidermal split depending on why those mechanisms are occurring. But you can always find these features, spongiosis, ballooning degeneration, at adjacent to the split. Now remember, if a split has occurred, so majority of the inflammatory activity is happening at the split, but here the destruction is so much so that the layers have separated. So you may not be able to appreciate subtle changes. So these subtle changes will be seen at the adjacent where the split is ongoing. That is why you see spongiosis and ballooning degeneration or other mechanisms adjacent to the split, because here the destruction is not so severe to cause the overshadowing of these subtle histological findings. It doesn't include Supra-Basal Split. We'll discuss that separately. The examples of intraepidermal split include allergic contact dermatitis, pneumodermatitis, Pemphigus vesicular type PMLE, Palmoplantar Pustulosis, insect bite reactions, incontinentia pigment type first stage, malaria rubra, acrodermatitis enteropathica, friction blisters, and one thing in common that you must have realized, these are all spongiotic disorders. We have discussed some of them in the last week's lecture when we were discussing spongiform tissue reaction pattern. And now you understand why spongiosis is easily picked up at the adjacent, because that is the majorly underlying mechanism of the intraepidermal split. Okay, so let's move forward and we'll discuss intraepidermal splits, taking one examples from for the intraepidermal separation. Let's move forward. We'll start with Palmoplantar Pustulosis. In this disorder, we have a spongiotic vesicle which is unilocular, that means single, solitary, individual, well delimited pustule, that means well defined, okay, collected, localized to a certain area. Over the pustule, you have overlying focal parakeratosis. Now remember, in subcorneal split, the stratum corneum will be damaged because it's the thinnest layer, it's the weakest layer, it will easily get damaged. But in intra-epidermal split, the stratum corneum would be preserved to a certain extent. And when stratum corneum is preserved, you'll be able to appreciate parakeratosis. So in the previous disorder, when we were discussing subcorneal split, the destruction was so much that there was no meaning of parakeratosis. But here, the layers which are involved are responsible for forming stratum corneum. And if the layers are damaged, the stratum corneum will not be formed properly and you will have parakeratosis. Because remember, wherever there is parakeratosis, there is abnormal keratinization. We are clear about it? So since the germinating, the proliferating layers are affected, it is leading to abnormal keratinization or parakeratosis. The dermis will show mixed perivascular diffuse infiltrate or inflammatory cells. Okay, so we'll focus more on the split. Let's see the slide. So look at this slide from Whedon's, and you can see a localized collection of neutrophils. You can see so many inflammatory infiltrate in between. Look at this in large collection of inflammatory cells, destroyed keratinocytes. And as we said, it is unilocular. Can you appreciate how localized this vesicle is? Now, the same morphology we have seen last time in SCPD, subcorneal pustular dermatosis. But in SCPD, the split is just below a stratum corneum. So the roof would be formed by only stratum corneum or a destroyed stratum corneum. While in intra-epidermal split, the roof will have intact stratum corneum. Okay, so let me get rid of these markers. And you can see that the stratum corneum is intact. In fact, it is showing a bit of parakeratosis. So here is parakeratosis. You can look at the nucleus inside in the keratinocytes. Okay, I'll get rid of the markers so that you can see the dotted nucleus here. So you can see parakeratosis. So unilocular vesicle with inflammatory cell infiltrate overlying the vesicle, there's parakeratosis. You're dealing with palmoplantar pustulosis. Clear, there's mild infiltrate at the dermal level that we know. Here, this whole area is infiltrated. We know about it. So now we have discussed very shortly a biopsy from palmoplantar pustulosis. Let's move forward. Now, the other mechanism that underlies intraepidermal blistering is ballooning degeneration. And that majorly you see in viral blistering diseases. Diseases like herpes simplex, herpes zoster, varicella, hand, foot, and mouth disease. Okay, virally, the etiology is a virus infection in these kind of disorders. These the in cells which are infected by the virus. So you have a keratinocyte, and then you have how to draw a virus quickly. I'm just drawing a bacteriophage. So when the virus infects a normal keratinocyte, the cell will get damaged. It will form a lot of copies of the virus. The cell will get enlarged. There will be a lot of viruses inside, and then the cell will burst like a balloon bursting. Okay, the cell will burst, and that cell will then degenerate, and that is known as ballooning degeneration. Okay, so the mechanism in viral blistering diseases is ballooning degeneration of keratinocytes, and you have secondary acantholysis. Why? See, acantholysis happen when when the keratinocytes lose the attachment to other cells by any defect. But here there is no defect. Here the cell is dying. And if your connections, let's say you have held hands of your friends like this, and if you are suddenly disappeared, your friends will become, acantholytic cells. Try to understand the concept. So here the attaching, let me just see if I can draw it out. So let's say there are three cells perfectly fine, happy in the world, and there are three cells, and if the attachment is lost, they will become acantholytic cells. Clear? That's what I've said. But what would happen if the center cell is destroyed? The other cells now are not attached to any other cells, and they will become acantholytic cells. So that is known as secondary acantholysis. That means the cell is gone, the attachment, there's no problem in attachment, but there's no cell to attach to, and that is known as secondary acantholysis. You will also see multinucleated giant cells like we usually observe when we do Zinc smear from an herpetic ulcer. Okay. Now look at this slide I've taken from pathology outlines. Look at, can you appreciate this multinucleated giant cell? Let me change the color. Look, multinucleated keratinocytes. So many nucleus, 1 nucleus, 2 nucleus, 3 nucleus, 4 nucleus, 1 nucleus, 2 nucleus, 3 nucleus. Okay. Can you see this multinucleated giant cell? Here also you have a giant cell. So many giant cells. Okay. A little bit of ballooning degeneration is observed here. Can you see spongiosis like picture? A picture like it is showing some localized spongiosis. And when you look closely, you see that some of the cells have empty spaces in between because they are undergoing ballooning degeneration. And if the degeneration is vast, it will lead to a split like this. An intra-epidermal split because of ballooning degeneration seen in virally infected cells. Let's move forward. Okay, so now coming to, I think, one of the most interesting aspects of vesiculobullous reaction pattern, one of the most commonly encountered mechanism of split, the supra-basal split. And here what is, let me just draw it again. This is the basal layer, mm, basal layer. Any split that happens just above the basal layer, just above the basal layer is a supra-basal split. Clear? So you will have basal layer in the floor and all the other layers of the epidermis in the roof. Clear? And that is what we see in Pemphigus group of disorders. So let's introduce Pemphigus group of disorders with the supra-basal split. In supra-basal split, the split happens just above the basal layer that we have told you about. If the epidermis is regenerating, the split can be higher. Now, understand the concept first, okay? You have the basal layer. Let's see, this is the basal layer, and all the other layers of the epidermis is like this. Okay, so this is a normal epidermis. With the red is the basal layer, the green is all the other layers of the epidermis. If a split happens, okay, if a split happens, the split will look like this, a suprabasal split. We are clear? If the epidermis starts to regenerate, there will be a new layer formation above the basal layer because all the keratinocytes will grow from the basal layer only. That's how normal epidermis proliferates. So you will have two different sections underlying the split. Okay, for example, if the epidermis has started regenerating, that means it has started, okay, that means it has started to form newer layers. You will see newer layers above, sorry, below the split, and above you will see the older layers. So slowly, as the skin will move upwards while proliferating, the split can be seen a bit up, and you might make a wrong diagnosis of an intra-epidermal split. But you have to carefully examine the floor and see if these are newer layers of the epidermis or the older layer of the epidermis. Okay, so in regenerating epidermis, the split can be higher. You can make an error in diagnosis, and you can label it as an intraepidermal split, while it was actually a suprabasal split. We're clear about it. If you have any confusion in this concept, just mention in the comments, and maybe I'll just discuss in that. Okay. Now, individual basal keratinocytes, that means the cells at the basal layer, they become separate from each other, but they are still attached to the dermoepidermal junction. And their attachment to the dermoepidermal junction, but separation from the neighboring cells gives them an appearance which is known as row of tombstones. Okay, so in row of tombstones, let me get rid of everything. Yeah. So in row of tombstones, let me explain what actually happens. You have the dermoepidermal junctions. Okay, so here you have the dermoepidermal junction. Okay, and here you have the basal cells. They are firmly attached by desmosomes. So the yellow bars are desmosomes. Okay, and they are firmly attached to their neighbor cells with the desmosome. But if you have a split, And these desmosomes are vertically also. So you can see vertically also. Okay. Now these vertical desmosomes are attached to the cells above. The horizontal desmosomes are attached to the neighboring cells. If these desmosomes are destroyed, the cells will become separate. Okay, they will become separate and they will give the appearance of a row of tombstone. This is a tombstone like you have in graveyards and cemeteries. Okay, and this looks like a row of tombstones, and that is what we mean by row of tombstones appearance. The other additional features are the acantholytic cells. Individual keratinocytes would acquire a spherical shape. See, anybody with the limited surface area but a maximum volume, a good shape to acquire, okay, is a spherical cell. That is why in zero gravity, the water tends to become spherical. All of us have seen videos of zero gravity in space stations. The water will tend to assume a spherical shape. The same thing is happening to a keratinocyte, and that is why catalytic cells are larger spherical cells. Clear? Let's move forward. The examples include Pemphigus vulgaris, Pemphigus vegetans, Hailey-Hailey disease, Darier disease, Grover's disease. So all the major vesiculobullous disorders, all the major Pemphigus group of disorders, you will see having a supra-basal split. Let's start a discussion with Pemphigus vulgaris. There's a supra-basal bulla with acantholysis. Clear? That is how you describe a biopsy. Supra-basal split with acantholysis. Clefting may extend to the adnexal structures. There is row of tombstones and acantholytic cells. You have to say these two lines when you're describing pemphigus, otherwise no marks. In vegetative lesions, you can have epidermal hyperplasia, but less eosinophils. Okay, in vegetative lesions. In Pemphigus vegetans, you can have a lot of eosinophils. But in Pemphigus vulgaris, especially the vegetative variant, you will have epidermal hyperplasia. That is why the vegetative variant is there, but the eosinophils will be less. In later stages, acanthoma can happen, and acanthoma following Pemphigus disease is now a well-known appearance of Pemphigus lesions. Okay, dermis has mild superficial mixed inflammatory cell infiltrate, predominantly at the perivascular location, because that's how autoimmune blistering disorders start. So look at this slide. Now what we're looking at an area adjacent to the split. Okay, here is the split. This is the split. And if you look at the area adjacent to the split, what you're looking at is spongiosis. Okay, look at this spongiosis. And this spongiosis is localized majorly at the deeper layers of the epidermis, lower layers of the epidermis. You can in fact see the basal cell here. They're trying to form row of tombstones. Okay, and sorry, if these vesicles become coalesce together, they come together and they become large, it will lead to a split, and that is what you're seeing here. Look at here, this is a split, and this is a row of tombstones, and these individual cells are nothing but acantholytic cells. These are acantholytic cells. This one is, I think, a neutrophil. Let me erase that. Yeah, this one is, I think, a neutrophils, but all of the cells, the larger cells, are acantholytic cells. Let's see the split. Now this is the same picture, but I've shifted the level here. And this large area is the split, and it is suprabasal. Can you see that the basal layer, the floor, is made by only the basal layer? And you can have this row of tombstones, appearance of the basal layer and the acantholytic cells. Acantholytic cells. That is two things that you see in Pemphigus vulgaris. Clear? Let's move forward. Now this is Hailey-Hailey disease, and the term that we use is dilapidated brick wall appearance. Okay, I'll see if I can find a photo of dilapidated brick wall. I'll add it to the slide. So in dilapidated brick wall appearance, it looks like a brick wall, a wall made up of brick, but few bricks are missing in between. So here we can see those bricks which are missing. Okay, so this split, this supra-basal split, you can see the basal layer here. Okay, the supra-basal split is there, and you can also see some dyskeratotic keratinocytes. Dyskeratotic Hailey-Hailey disease is an example of dyskeratotic acantholysis. Okay, so dyskeratotic cells are seen. Hailey-Hailey disease histology is one of the most beautiful slides. Maybe we'll discuss that in detail, but we are just here to learn about suprabasal splits, and an example of suprabasal split is Hailey-Hailey disease or familial benign chronic pemphigus. Let's move forward. Now, this is Darier's disease, in which you will see acantholysis, coprons, and grains. Coprons and grains are localized here. So these are nothing but dyskeratotic keratinocytes assuming different shapes. When they were named as coprons and grains, people thought that it is something different, but they have nothing but dyskeratotic acantholytic keratinocytes, or just an abnormal form of keratinocytes. And you can see a large suprabasal split. Large suprabasal split. Okay, let's move forward. Now, sub-epidermal split. All of the disorders that are left majorly will be covered by sub-epidermal split. In sub-epidermal split, the split is there below the epidermis, as the name suggests. So the split happens at the level of dermoepidermal junction. Dermoepidermal junction. Okay. So the roof will be made up by majority of the epidermis. The floor will be made up by dermis. We are clear about it? Now let's slowly discuss individual disorders and go into much more details in the subepidermal splitting disorders. This diagram, the last you have seen this diagram was in the lecture series on epidermolysis bullosa, and this is just to show you the level of splits. In EB simplex is majorly the entire epidermis, anywhere the split can happen. In junctional EB, it happens at the level of lamina lucida. In dystrophic EB, it happens at the level of lamina densa and sublamina densa, below the lamina densa. Now, to understand the disorders like EB or any other attachment disorders, I would request that you go back and see a three-part series on basement membrane zone. So if your knowledge about basement membrane zone is good, you will easily be able to understand where the split is happening. So I'm not going to details how the layers are formed, how the layers are attached to each other, because I've already covered them in exhaustive detail in my lectures on basement membrane zone. So go back, search in the channel, and you will see good lectures on basement membrane zone and epidermolysis bullosa, the group of disorders, and there we have covered in detail about various proteins which are implicated. We are here to discuss only histopathology. So let's move forward and start. The first disorder is EB simplex. Here the roof is made by the epidermis, while the floor is made up by BP antigen, the Bullous Pemphigoid antigen, laminin, type 4 collagen, and the lamina densa. That means the split is happening at the level of lamina lucida. There's minimal inflammation. Now remember, in acquired bullous disorders, in an example of which is epidermolysis bullosa, you will see minimal inflammation because there's no inflammation going. It's because of a genetic defect that the split is happening. Okay, so let's move forward. So can you see that this split actually reminds you of Pemphigus vulgaris? But look at that, there is no inflammation. Okay, can you see that the inflammatory process, the dermis is normal, the epidermis is normal. There's only one defect, that there's a split between the dermis and the epidermis. Okay, if you look closely at areas, certain areas, even the basal layer has separated. And that is why, because the attachment molecule is at the defect. This is not a slide from from Pemphigus vulgaris. This is a slide from epidermolysis bullosa simplex. Clear? Let's move forward. So minimal infiltrate, split. Let's move forward. In junctional EB, the roof is made up of epidermis and the Bullous Pemphigoid antigen. So now we have gone a bit deeper, and the Bullous Pemphigoid antigen, which was at the floor in EB simplex, is now at the roof of the junctional EB. Okay. The floor is made by the rest of the basement membrane, laminin, and type 4 collagen. So look at this slide. You cannot appreciate any basal layer in the floor. No basal layer in the floor. It is just the dermis. Okay, this is the dermis. Above is epidermis. Apart from that, there is nothing wrong but a split. So minimal inflammation, no inflammation, just the split. That is what you see in epidermis bullosa. No inflammation, only split is the problem. And you can see that the floor is made up of dermis, no basal cell layer, so EB junctional. In dystrophic EB, the roof is made up of epidermis, bullous pemphigoid antigen, laminin, type 4 and type 5 collagen, while the floor is made up of dermis. Now, a question would naturally arise. How do you differentiate between dystrophic EB and junctional EB on the basis of biopsy? A good answer would be you cannot. Okay, do an electron microscopy. Okay, do a salt smear, do all sorts of different investigations, do an indirect immunofluorescence. Okay, and that is how you're able to separate dystrophic from junctional. And if you have gone through a lecture series on EB simplex, EB disorders, you will understand that sometimes it is difficult to separate dystrophic and junctional EB. There are only subtle clinical changes and sudden genetic changes which you can easily differentiate. So we are not going to go into this. We are just going to discuss how dystrophic EB looks under a microscope. So at dystrophic AB, the biopsy is nearly same to same as junctional. You will just see a bit of inflammation in the below, but that inflammation is very low as compared to any autoimmune disorder, any inflammatory disorder. In EB, the slides from epidermolysis bullosa lesions are cleaner because you don't have inflammatory infiltrate. All you have is a split. So you can easily appreciate that the epidermis is normal, the dermis is normal. All you have is a split. Clear? Let's move forward. Now, the next disorder that we'll discuss is bullous pemphigoid. You could say the prototype of subepidermal blistering. So in bullous pemphigoid, you will have subepidermal blisters with eosinophils, and that is important. You have to mention it in a single line, subepidermal disorder with eosinophils. The eosinophils may line up along the basement membrane or within the epidermis. You have the eosinophils in the split. You can also have them in the epidermis and the dermis itself. Okay. The dermis has minimal to heavy infiltrate in the upper dermis. There is epidermal necrosis. Can or cannot be depending on the level of inflammation. And direct immunofluorescence gives you a linear homogeneous distribution of IgG and or C3 along the basement membrane zone. So in bullous pemphigoid, the antibodies are against the bullous pemphigoid antigen, and that antigen is found at the basement membrane zone. So if you stain for those antibodies, it will stain the basement membrane zone. And that is what you see. You see a linear deposition of Ig and C3 antibodies along the basement membranes, because that is where the problem is. Let's move forward. So look at this split. First of all, whenever you look at a split, you decide what is the level of split. Okay. So the anatomical level of split is, you can see above here itself, there is nothing but epidermis. This is epidermis. You can see below is dermis. There is no basal layer in the floor of the split. All the layers are above the split. So it's a subepidermal blister. We clear about it? Now look at the cell composition of the split. You can see multiple neutrophils, a bit of lymphocytes, a little bit of red staining, bilobe nucleus, eosinophils. So these are all, let me use different color. These are all eosinophils. Eosinophil. And before I get mad, eosinophils. So there's so many eosinophils in the blister cavity. Okay. And that is a biopsy of bullous pemphigoid with a lot of eosinophils. This whole area has a lot of eosinophils. I'm not going into detail. Let's move on. So we have essentially expanded that area to look at our precious cells eosinophil. This is an eosinophil. Can you easily recognize that eosinophils are nothing but, red stained cell? With two lobes, roughly two lobes of nucleus, and you can easily see so many eosinophils, perfect eosinophil. So eosinophil rich inflammatory infiltrate with a subepidermal blisters. Think of bullous pemphigoid. Let's move forward. Now, prior to this, we have discussed splits at nearly all levels of the epidermis. Now let's change a bit. Let's change the inflammatory infiltrate and include a bit of neutrophils now. Remember, whenever there's an infection or inflammation, the first cells to come will be neutrophils. We have discussed that while discussing Impetigo. Now we'll see a sub-epidermal split with majorly neutrophils, and I know that most of you know the answer of the disorder that we're talking about. We are talking about dermatitis herpetiformis. Okay. In dermatitis herpetiformis, there's collection of neutrophils and eosinophils at the tips of dermal papilla, and that forms papillary microabscess. Remember, wherever there's collection of neutrophils, there's abscess. Okay. So what essentially happens is, let's see, this is the dermoepidermal junction. At the level of papilla, you will have neutrophilic inflammation. Let me just change the color. So neutrophilic inflammation, neutrophilic inflammation, neutrophilic inflammation. So essentially at the tips of dermal papilla, you have papillary microabscess composed of predominantly neutrophils and eosinophils. Okay. So you have to remember tips of dermal papilla. You have a lot of acantholytic cells and fibrin, which can be seen. Eosinophils can increase with time of the biopsy. If you take an earlier biopsy, you have little eosinophils, which increases with time. In direct immunofluorescence, you will have granular deposits of IgA in the dermal papilla of perilesional and uninvolved skin. Why granular? Because look at this. The deposition or the presence of microabscess is at the tips of the papilla. So if you stain these areas, let me just change it. Yeah, if you stain these areas with direct immunofluorescence, you will see granular. Okay, isn't it? You will see it as some granules, individual dots in that immunofluorescence. That is what we mean by granular deposits of IgA. Okay, let's move forward. So this is a biopsy from Dermatitis herpetiformis lesion I've taken from Beedens, and you can see this huge collection, not huge in the proper sense, but a large localized collection at the tips of dermal papilla, and majority cells, the major cells are neutrophils. Okay, so neutrophilic papillary microabscess with a subepidermal split, dermatitis herpetiformis. Let's move forward. And now this is direct immunofluorescence in which you can appreciate and easily see granular deposits here. Okay, so you can see this dot-like image. I should change the color. Nothing is actually seen. Just give me a minute. Yeah. So you can see these granular deposits, like dot, 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 dot. These are the antigen antibody complexes. They are majorly of IgA type. So granular deposits of IgA are seen in direct immunofluorescence of dermatitis herpetiformis. We are clear? Now, when IgA is deposited in this kind of granular pattern, it's a biopsy from dermatitis herpetiformis. We are clear about it? What happens if it is deposited linearly like a line? Linearly IgA, you have linear IgA bullous dermatosis or LIGA. Linear IgA bullous dermatosis or LIGA, and in pediatric population, chronic bullous disease of childhood CBDC. Okay, so as the name suggests, there will be IgA deposition, but linearly, not granularly, linearly. So you have subepidermal blisters with neutrophils. We are discussing that. But contiguous dermal papillary tips are involved. What do we mean by contiguous? That means one after the other dermal papillary tips are involved, and it will lead to a contiguous linear deposition of IgA, and that is what you see in direct immunofluorescence, linear deposits of IgA. Let's move forward. So in linear IgA, you can see the subepidermal split and the major cells are neutrophils. I know it's a very less magnified image. You're not able to appreciate neutrophils, but the least that you can appreciate is that the infiltrate is confined to the split. There is a little bit of perivascular infiltrate here, but it is majorly confined to the split, and it is majorly bluish looking. Okay, so that is a hint towards neutrophilic infiltrate. And this is a magnified image, and you can easily appreciate that there's a contiguous inflammation, and this inflammation is majorly consisting of neutrophils. And you can see individual splits in between. This is a biopsy from linear IgA disease. We clear about it? Let's move forward. This linear IgA deposits, uh, compare it with what you have seen in Dermatitis Herpetiformis. In that you had granular areas, okay? But here you have a linear, unbroken line, okay? And you have stained for IgA. So linear IgA group of disorders or LIGA. Let's move forward. Some other examples of subepidermal split with neutrophils include mucous membrane pemphigoid, cicatricial pemphigoid, and in both of this you will see scarring at the floor, scarring or fibrosis at the floor. Okay, anti-P105 pemphigoid, anti-laminin gamma 1 pemphigoid, bullous lupus erythematosus, bullous Swedes. Remember, Swedes is nothing but a neutrophilic dermatosis, neutrophilic dermatosis, and in EB acquisita. So these all are examples of subepidermal split with neutrophils. Let me remove this. Okay, so you can take a screenshot to learn examples where the inflammatory infiltrate is predominantly neutrophilic. Let's move forward. So with that, again, read the textbook of Dermatopathology by IDVL. Read this pathology of skin. It's a shorter read, very small read. Okay, and just go through this video. It's more than 1 hour of information only on vesiculobullous reaction pattern. So that is all you require. These are further reading recommendation. Again, Whedon's Fundamentals of Pathology of Skin, Mackey's IDVL textbook, Pathology Outlines. This is a very good resource if you want to look at good quality slides. There's also other disorders, DermNets, DigiScan. These are all areas where you can get access to good quality slides. But go to your college's pathology department and see if they can let you look at these skin slides. I mean, majority of the medical colleges skin department have a certain section for the slides where you can see and easily understand the histopathology. But if you don't have access to it, go and see the natural slides. Go and see how normally these disorders look on a glass plate on the stage of the microscope. So with that, I'll finish this week's lecture on vesiculobullous reaction pattern. It's a long lecture, but this is all you need to know about vesiculobullous reaction pattern. The motive of these lectures is to go in detail and understand the concepts which are there underlying these disorders. Okay, it's easier to understand or even in fact remember the examples if you know what exactly is happening. So in this lecture we have gone through the anatomical levels of split from top to bottom, isn't it? And we have dealt with at least two examples from each. We have touched upon the pathomechanisms of individual disorders, majorly cell population or cell type of individual disorders, and that is how you create an understanding. So in the future, when we'll be discussing vesicobullous disorders or autoimmune blistering diseases like pemphigus and bullous pemphigoid and cicatricial pemphigoid, I will request to come back and see this video and to understand what exactly or where exactly the step is happening. If you have gone through this video, I can practically guarantee that your concepts regarding vesicobullous group of disorders are much clearer than before. With that, I'll further will not take much time. I'll finish this. All the comments can be made about the video regarding suggestions or any doubts with a timestamp. You can email me also, but it's better to comment. With that, I'll finish this lecture. Adios and bye bye.